Pituitary Network Association is a nonprofit organization that relies on the support of our members and donors. We offer this webinar series to help educate patients, their families, and their healthcare providers. During the webinar, feel free to type in your questions at any time, but please note that all questions will be saved until the end of the webinar. We've allotted time to answer as many questions as possible. Any questions that are not answered will be reserved and answered by email. Today's webinar, Empty Sella Syndrome, will be presented by Dr. Manish Aghi, Associate Professor and Resident of Neurological Surgery at UCSF and attending neurosurgeon for the California Center for Pituitary Disorders. Dr. Aghi is a neurosurgeon specializing in the treatment of pituitary adenomas and other tumors of the anterior skull base by minimally invasive nasal approaches. He has an MD and PhD from Harvard Medical School in Boston and did his neurosurgery residency at the Harvard-affiliated Massachusetts General Hospital. Since joining UCSF 6 years ago, he has performed nearly 500 endonasal operations for pituitary tumors, and as the leader of an active clinical research program, he has published 24 articles on surgical technique and outcomes for pituitary tumor patients. He is currently directing a national effort sponsored by the Congress of Neurological Surgeons to establish evidence-based guidelines for neurosurgeons caring for patients with pituitary tumors. Dr. Aghi also runs an NIH-funded basic science laboratory investigating the molecules that allow pituitary tumors to grow and invade, and he is working with industry collaborators to develop molecular inhibitors that may someday be of benefit to prevent these processes. He is principal investigation of a pair of phase 1 and 2 clinical trials of experimental treatments for malignant brain tumors. At this point, we're going to turn it over to Dr. Aghi. There may be a brief delay as we change presenters. Okay, I can see your screen. It's all yours.
Thank you very much. I appreciate the opportunity and the invitation from the Pituitary Network Association to speak to you today about the empty sella syndrome, which is a commonly diagnosed entity for those of us in pituitary who treat patients with pituitary disorders, and it can create some confusion and anxiety for patients as well as referring providers. And so my goal today would be to hopefully shed some light on that and obviously answer some questions at the end. So by way of overview, I wanted to speak today, briefly introduce the topic of empty sella syndrome, and then I'll talk about primary empty sella versus secondary empty sella, which I think is the biggest distinction between the different variants of empty sella syndrome. I'll spend a little bit of time talking about visual symptoms. There's a number of possible symptoms, but I wanted to specifically isolate visual symptoms and spend more time on that. And then lastly, management of empty sella syndrome. When do we need to do something for a patient with this finding? And so by way of introduction, the empty sella syndrome was first described in 1949 by a pair of British physicians, pathologist Harold Leeming Sheehan and a consulting physician, Vincent Sumners. And both of them had studied pituitary gland destruction, cases where patients' pituitary glands were destroyed by various pathologic processes. And they actually had a famous report by the same Dr. Sheehan that ended up giving the name Sheehan syndrome to a rare complication of pregnancy in which the anterior pituitary gland is damaged. But in the report in question, which you see the abstract below, they submitted this in 1948, and they described a general group of patients, all of whom, not just pregnant patients, but all sorts of patients who had destruction of the pituitary gland. And Dr. Sheehan and Sumners looked at these by X-ray, which was what was available at the time, and described these patients as having what they called an empty sella. So normally the sella turcica, or Turkish saddle, which I've highlighted with the cursor, is what is the bony aspect of the skull base that houses the pituitary gland. So on a normal MRI, at the time they didn't have MRIs, they just had X-rays, you would see soft tissue in the sella turcica. But Dr. Sheehan and Sumners described this group of patients in whom the pituitary gland shrunk or became flattened, and the sella turcica, rather than having pituitary gland, filled with cerebrospinal fluid. and they called this an empty Sella because rather than having the soft fullness of the pituitary gland, it just had fluid and was therefore empty. So really what that hammers home is an important point, which is that empty Sella is not a clinical diagnosis, it's a radiologic diagnosis. It describes the picture that you see on the patient. But ultimately, the patient with an empty Sella, it may just be an incidental finding, or it may actually be part of some process or syndrome, and that's the challenge that we face when evaluating these patients. So we're focusing purely on the radiology. The challenge in rendering the diagnosis of empty Sella syndrome that not just radiologists but endocrinologists and surgeons and other providers face is being sure that that is what you're seeing. And most commonly, the other things we would think about in a patient where empty Sella is a possible diagnosis would be various cystic structures of the pituitary gland, such as an epidermoid cyst, an arachnoid cyst, a Rathke's cleft cyst, a cystic adenoma, or a craniopharyngioma. And the question becomes, how do we know that that's what the patient has, i.e. empty Sella, versus any of these 5 cystic entities? And rather than walk you through each of those 5 individually, I would just tell you that the classic sign differentiating ESS or empty Sella syndrome from other cystic cellular lesions would be to look for the infundibulum sign. And so the infundibulum sign is when the pituitary stalk, shown here, this gray vertical line on the left and this gray vertical line on the right in a sagittal image, the pituitary stalk should normally be obliterated or pushed up if you had a true pathology in your Sella. But if it were empty Sella, just full of spinal fluid, the stalk actually gets stretched all the way down. So normally a pituitary stalk should lead you to the gland, but this is a stalk that's really long and stretched, leading to this thin, flattened pituitary gland at the base of a Sella filled with spinal fluid, as shown in gray, indicating a empty Sella. And similarly here, the spinal fluid is bright white on the T2 coronal image on the left, and the pituitary stalk is traversing that spinal fluid to get all the way down to the bottom, where there's maybe just a thin rim of pituitary gland connecting that stalk, which is really stretched, and you only see that sign in a patient with an empty Sella syndrome. So how do we classify the different types of empty Sella syndrome? And I'll talk about this throughout the talk, but I wanted to provide this background here. So the first way we could classify this is the empty Sella partial or is it total? A partial empty Sella syndrome is when less than half of the Sella is filled with spinal fluid and the rest is filled with a small but present normal gland. And the thickness of that gland should be about 3 to 7 millimeters, 7 being the lower limit of normal in normal patients. And so you can see here an example where there is a little bit of pituitary gland whose thickness is right around 3 millimeters at its smallest and maybe a little bit larger on the sides. And a little bit more than half of that gland, of that Sella, is filled with gland, and a little bit less than half of it is filled with spinal fluid. So that's a partial empty Sella. A total empty Sella would be when more than half of the Sella is filled with CSF and the gland thickness is less than or equal to 2 millimeters. So you can see here a very small gland, 1 to 2 millimeters, and 75 to 80% of the Sella is filled with spinal fluid in the images on the bottom there. Another way we can classify empty Sella syndrome is it primary or is it secondary? The idea being, is it something that just appears to be the patient's anatomy, i.e. primary, or is it somehow secondary to some destructive process within the pituitary gland? So a primary empty Sella is felt to happen when a patient has a small anatomical defect above the pituitary gland that somehow increases the pressure in the Sella, causing the gland to get smushed or flattened out against the inferior walls of the Sella turcica cavity. On the other hand, a secondary empty Sella is when there's some sort of process within the pituitary gland, a tumor or inflammation, and that causes the gland to regress after that process resolves, leaving the patient with a secondary empty Sella. So let's talk a little bit in more detail about both primary and empty Sella syndromes. We'll start with the primary empty Sella. So as I mentioned, the primary empty Sella is due to a combination of a defect in the diaphragma Sella, which is the barrier between the pituitary and the brain, and then a increase in the intracranial pressure of CSF driving spinal fluid or CSF through that defect into the sella and squishing the pituitary gland. So it's really felt that these patients have a primary process that causes them to have an empty sella, and the pituitary is really just an innocent bystander or victim of that process. And these conditions with primary empty sella are really going to be seen in patients who have some reason to have an elevated spinal fluid pressure. And the three examples we'll see are pregnancy, obesity, which can increase a patient's retention of carbon dioxide, which would be associated with chronically elevated cerebrospinal fluid pressure and cause herniation of the supracell subarachnoid space down into the sella and promote a primary empty sella syndrome. And the third example would be benign intracranial hypertension, which is a condition called pseudotumor cerebri, seen also in patients with obesity, where they have elevated cerebrospinal fluid pressure. Those three conditions, pregnancy, obesity, and pseudotumor or benign intracranial hypertension, can increase the patient's CSF pressure, which in combination with some sort of defect in that diaphragma sella can cause these patients to have a primary empty sella syndrome. What is the incidence of primary empty sella syndrome? If you look at all sorts of studies of patients undergoing autopsies or volunteering to undergo an MRI, it's quoted to be anywhere from 5.5% to 35%. I suspect it's really more the former than the latter, but it's just important to illustrate that this is a common finding on MRIs, and it often doesn't mean anything, but it does occur pretty frequently. So one group from Argentina studied 175 patients who presented to their clinic with a radiographic finding of primary empty sella. And they found, and several groups have reported this, that the syndrome was 6 times more common in women than men. The patients on average were in their 40s, and this has really been pretty consistent throughout the literature. And more typically, they would have a total empty sella syndrome, but there were a number that also were found to have the partial variant as well. The same group then went on to characterize the signs or symptoms that were associated with this in these patients. More than half of the patients had a headache, and again, that doesn't mean that it's a cause of the primary empty sella or somehow related, but it just means that the patients who had the primary empty sella also had a headache. 58% of these patients were women with 58% of the women had multiple pregnancies. That's felt to be a risk factor as well. Half of the patients had obesity. More than a quarter had high blood pressure, and about 14% had some sort of visual disturbances, but it should be noted that pseudotumor cerebri patients, which are a portion of these patients, have visual disturbances even when they don't have empty sella, and so that is often a manifestation of that disease that may just coincide with the empty sella. And here you can see in pie chart format the reason that the patients with primary empty sella syndrome in this Argentinian study underwent MRIs. About 1 in 3 were for headaches, about 8.75% were for visual disturbances, about 3% were to work up high prolactin, I'll get to that in a moment, and 17% were to work up hormonal deficiencies, and the rest were for imaging findings seen on CAT scans or other vague neurologic symptoms such as dizziness. So I mentioned that a number of the patients in that study who had primary empty sella syndrome had the MRIs that were obtained to work up hormonal deficits of some kind. And so that raises the question of how common are hormonal deficits in patients with primary empty sella syndrome. And so this study, they had hormonal evaluation of these 175 patients. High prolactins were seen in about 12 to 17% of the patients, and so high prolactin is actually felt to be a manifestation of this syndrome. And then 16% had deficiencies of just one hormonal axis. Mostly it was hypogonadism, but all the axes were affected to some degree or another. 28% of the patients had some degree of more than one axis being affected, and 12% had panhypopituitarism of their anterior lobe. So that overall, if you pull these results together, 64% of the males with primary empty sella syndrome and 22% of the females had some degree of hormonal deficits. So one take-home message there is that the hormonal deficit, although the syndrome is more common in women than men, when the men get it, they are more likely to have a hormonal deficit associated with it than the women. There's another study that I found interesting from Turkey where they looked at primary empty sella syndromes and hormonal deficits, but in this study they stratified by partial versus total empty sella syndrome and found that the total empty sella syndrome patients had a far greater degree of hypopituitarism across each individual hormonal axis as well as in total. So if we put these studies together, we see that hormonal deficits in empty sella syndrome patients are more common in men than women and are more common in patients with a total empty sella rather than a partial empty sella. And here's another interesting hormonal study. It was actually a clinical trial that was conducted in the States in which they enrolled obese patients in whom the provider felt that there were signs or symptoms of growth hormone deficiency. And so this is an interesting study because it ties together two phenomena. Growth hormone deficient patients can become obese, and obese patients can have primary empty sella syndrome. And so the question was, can we tie these things together? And so they enrolled 906 obese patients in which they had 184 with signs or symptoms of growth hormone deficiency who then underwent testing, and 70 of them were confirmed to have growth hormone deficiency. And interestingly, virtually all of the patients, all 70 patients with confirmed growth hormone deficiency and known to be obese had MRIs showing primary empty sella syndrome. And about half of the patients who had normal growth hormone testing, there was a primary empty sella syndrome. So the background level of primary empty sella in these obese patients who were suspected to have growth hormone deficiency was about 50%, but if they had confirmed growth hormone deficiency, it was virtually 100%. So moving on to secondary empty sella syndrome. Secondary empty sella syndrome, as I mentioned, is really seen after conditions in which the pituitary gland has had undergone some sort of treatment or process. This can be an autoimmune process that has resolved over time, or it can be a pituitary tumor that has undergone treatment, and when the tumor regresses, the patient is left with an empty sella syndrome. These are more common in clinical practice than a primary empty sella syndrome, i.e. if I'm an endocrinologist or a neurosurgeon running my practice, I'm obviously going to have a lot of patients with hypophysitis or pituitary tumors, and over time I may pick up on more and more of these patients who develop empty sella syndromes. But that doesn't mean that the incidence of a secondary empty sella syndrome is high. In fact, it's far less than primary empty sella, which I quoted to be about 5% or 5.5% in healthy volunteers undergoing MRIs. Obviously, if you had a healthy volunteer undergoing an MRI, you wouldn't necessarily pick up on a treated prolactinoma because they wouldn't be a healthy volunteer. So it gets confounding in that way, but it is still a common thing in clinical practice to have a secondary empty sella syndrome. Secondary empty sella syndrome patients, in addition to having an empty sella, can have an expanded or enlarged sella because they had a process there, such as a tumor, whereas a primary empty sella patient will virtually never have an expanded sella. They'll just have an empty sella. So one of the unanswered questions is what determines which patients with hypophysitis or abscesses or tumors will undergo resolution of the process and go on to develop a secondary empty sella syndrome. And the question becomes, does it require that the resolving pituitary process occur in a patient with a defect of the diaphragma sella, which was one of the requirements for primary empty sella, or is it just one of these random things that just happens to a small percentage of patients undergoing treatment or resolution of a pituitary process? So I'm going to give you two examples from my clinical practice. These were published in the book that the Pituitary Network Association produced a few years ago, in which I was fortunate to author a chapter on empty sella syndrome. This is a 53-year-old male who had acromegaly, and at the time of his clinical presentation, he had a 3-millimeter microadenoma. But what was interesting is if you actually measured his pituitary sella, he was found to meet the criteria for a partially empty sella, i.e. he had more than half of the space filled with, a little less than half of the space filled with CSF, and the gland size of his gland was 3 to 7 millimeters. So this does happen from time to time, a patient with a small microadenoma who meets the criteria for a partially empty sella. And the question becomes, is it a microadenoma that arose in a partially empty primary sella, or is it a patient who at some point may have had a normal size sella with a large tumor that somehow infarcted or involuted or regressed over time due to maybe an apoplectic event that the patient was unaware of, and that caused the patient to develop a secondary empty sella. And it's hard to say for sure, but it is an interesting finding when we do see it from time to time. Here's another example of a clear-cut secondary empty sella. Patient had a 33-year-old female who presented with hypopituitarism and a visual deficit as shown in panels A and B. Cystic lesion that I drained, and this proved to be a pituitary abscess. A year later, it recurred as shown in C and D. Drained it again, and then this patient never recurred, went on antibiotics for the abscess. But a year later, now 2 years after the original diagnosis, as shown in the bottom, the patient had an empty sella. And this was just due to the inflammation from the abscess and the treatments. There really wasn't much in the way of normal gland left, and the space just filled with CSF. And this patient actually had just 1 to 2 millimeters of gland thickness left in the sella. So what do we make of patients with empty sella syndrome who have visual symptoms? This can be very confusing and challenging to interpret. These patients, in order to understand their visual symptoms, we first have to understand the normal anatomy. And so I've used this slide in a previous webinar in which I talked about symptoms from pituitary tumors, but I think this is important basic anatomy. You see here a patient's right and left eye, and you can see that the normal anatomy is that the fibers on the inside of the eye will actually receive light from the outside of space and transmit them in the inside of the nerve. And similarly, on the opposite eye, the left eye, the fibers on the inside will pick up information from the other outside of space, transmit them on the inside. And so the information peripherally, or in our temporal fields, is carried in the center of our optic chiasm as shown in blue. The information in the middle, not in the outside, is carried on the outside because there's crisscrossing. And so if you have compression in the central of your optic chiasm, you will lose peripheral vision or get what's called a bitemporal hemianopsia. And that's very classic for a pituitary tumor. But it should be mentioned that that is contingent or dependent on where the patient's optic chiasm is located relative to the pituitary gland. And about 80% of us, if you look at cadaveric specimens, our optic chiasm, as shown in C, will be situated directly over the pituitary gland. And a patient like that with a pituitary tumor will get what I talked about, the classic bitemporal hemianopsia, because they're compressing those inner fibers that carry information from the outside. And so they're only going to see the center of this Paris skyline. They're not going to see the outsides. On the other hand, 10% of us will have what's called a prefixed chiasm. So those patients, the optic chiasm will be over the bony tuberculum sella, which is situated in front of the pituitary gland. So if that patient has a pituitary tumor, it's going to go straight up and compress fibers that are behind the chiasm, which are the fibers that actually carry information from the outside. And that patient will get what's called a contralateral hemianopsia. So they'll lose the left or the right, but they won't lose that peripheral information. And 10% of us, on the other hand, will have what's called a postfixed chiasm, where the chiasm falls behind further back, and it's situated over the bony dorsum sella. And in that case, a tumor growing up from below will impact one optic nerve, left or right, and give the patient a monocular deficit. And so this comes up in empty sella syndrome when patients have vision loss. And the question becomes, how do we know that a patient who comes to you with vision loss and an empty sella syndrome, that the actual vision loss is due to the empty sella syndrome? And there's really 2 points of evidence that people have used to suggest that empty sella syndrome can cause vision loss. And the first is that many patients with empty sella syndrome will present with a diffuse vision loss, as shown here in visual fields, that is not really typical for other cellular pathologies. The second point of evidence, which is really the most striking, is that the theory behind how an empty sella can cause vision loss is one of chiasmatic prolapse, such that the chiasm falls into the empty sella, tugging those nerves and causing vision loss in those patients. And the proof that this may be the cause of vision loss in these patients, it comes from a handful of cases over the years where we can put stuff in surgically, elevate the chiasm, do what's called a chiasmopexy, and restore this optic chiasm to its normal horizontal flat position by putting fat or muscle into the sella. And in those cases where we've been able to do that surgically, a percentage of those patients can have an improvement of vision. And so, but on the other hand, there's an equally large contingent out there that argue that vision loss in empty sella syndrome patients is not caused by the empty sella syndrome. And the arguments that those providers will make is that obviously there's examples where vision loss can occur in the setting of an empty cella, and the patient may have a normal optic apparatus, and the vision loss must be due to something else for those patients. There can be normal visual function in the presence of optic apparatus downward herniation, and there's also a lack of correlation between the degree of downward herniation of the optic nerves and the severity of the vision loss in these patients. And I would argue that to some degree both are true, that in a significant portion of patients with vision loss and empty cella syndrome, there is no correlation. But having treated a few of these patients, I think there are examples where the downward herniation can be a source of vision loss. And so it's just important to keep that in mind when you take care of these patients. A group at Jefferson in Pennsylvania has looked at the question of, in our surgical patients with pituitary tumors, do we need to reconstruct the sella in order to prevent downward prolapse of the chiasm, i.e. is there something we can do as surgeons caring for these patients to make sure that they don't end up in this situation where their optic nerves are being pulled down into an empty sella. And so this group, by standard of their practice, do not reconstruct the sella, and they looked at 100 of their patients who had no sellar reconstruction after surgery, meaning no bone and no fat was being put in there, and they found that only 1 out of the 100 patients had a downward herniation of their optic nerves into this empty sella, and even in that patient there was no visual symptoms. And so their argument was that there's really nothing we can do as surgeons, that reconstructing the sella is a choice, but it's not one that has to be done in order to prevent chiasmatic prolapse. And so then lastly, we come to the question of management. How do we manage or take care of a patient with empty cella syndrome? When do we need to actually do something, whether it be something medical or surgical? And in order to tackle this topic, I wanted to break this down into 3 categories of symptoms, because obviously if you're managing a syndrome, you're not managing the empty cella. We're not trying to make the MRI look better. We're trying to make the patient feel better. And there's 3 symptoms that I've alluded to throughout this talk that I wanted to draw special attention to, and they are really the 3 classic symptoms of problems in the cella, not just empty cella, but pituitary tumors. They are going to be hormonal dysfunction, headaches, and vision loss. I tell my patients that all the time about pituitary tumors, and those are the 3 big ones. So starting with hormonal dysfunction, how do we manage a patient with empty cella syndrome and endocrine dysfunction? Well, this is really the easiest thing. I mentioned that the incidence of hormonal dysfunction in empty cella syndrome patients is very high, and it's high enough to warrant hormonal testing if clinically indicated. And if there is, and the reason I say if clinically indicated, obviously a patient who comes in with an empty cella syndrome, who's a super athlete and profoundly fit and has absolutely no symptoms of a reproductive or energy nature may not necessarily warrant hormonal testing with an empty cella syndrome. But if there is an endocrine dysfunction that's somehow symptomatic or even mildly symptomatic in a patient with an empty cella syndrome, then as with any patient with a hormonal dysfunction, treatment should be based on that symptomatology and should be supportive, i.e. hormone replacement. So pretty straightforward management of patients with empty cella syndrome and endocrine dysfunction. What about patients with an empty cella syndrome and headache? This is a figure from that same chapter I mentioned that we had put together on empty cella syndrome for the book that the Pituitary Network Association put out a few years ago, edited by Dr. Laws. And really, I think this is a flow chart here, but just walking you through it. If you have a patient with an empty cella and a headache, I think it's worth keeping in mind that you do want to look at that empty cella very carefully. And I've mentioned dynamic MRI here, but essentially it needs to be an MRI that somehow satisfies you as to whether or not there's a tumor hiding in that empty cella. And the reason is that if there is a tumor within the empty cella, the tumor itself could be the source of headaches. So if there is a tumor in a patient with an empty cella syndrome, you want to evaluate for is it endocrine active? Is it endocrine inactive? Does it need medical therapy, or does it need resection of the tumor? And if you are going to resect the tumor, does the patient need to have the some fat put in there to keep the chiasm elevated if they have an empty cella syndrome? So that's sort of the decision making if there is a tumor. If there's no tumor, now you've got a patient with an empty cella syndrome who has a headache. then the question becomes, is there a visual problem? And if there is a visual problem, we do a full fundoscopic evaluation. If the patient has papilledema or elevated intracranial pressure, then they may be in that category of primary empty cell syndrome patients who have elevated intracranial pressure, such as a patient with pseudotumor, and they may warrant a shunt to treat the elevated pressure, and that probably will help with the visual problems. It may even help with the radiographic empty cell syndrome. If the patient has just the visual field loss without elevated intracranial pressure and does have an empty cell syndrome, you want to look closely at where that chiasm is and see if they need chiasmopexy. Again, exceedingly rare, but something to keep in mind. If the patient has no visual problems and has an empty cell syndrome, you may just want to do a spinal tap to measure their intracranial pressure, and if it is high, they may have pseudotumor, i.e. if it's high and if they're obese, you might want to think about shunting them. But if they have normal pressure, no tumor, and they have empty cella with a headache, then you just want to treat the headache. But these headaches can be complicated and can be, are probably best managed by a neurologist with some experience in managing these patients with headaches. What about vision loss in a patient with empty cella syndrome? I mentioned chiasmopexy. So what exactly is chiasmopexy? And here you see a diagram of basically filling this empty cella with muscle or fascia, reconstructing the bone with a patient's autologous cartilage graft, and doing so in a manner that restores the normal anatomic position of the optic chiasm. So the question is, does that help improve vision in these patients? And there's a few case reports of this. I myself have had 2 patients where I've treated them and had some improvement in vision with a chiasmopexy, but that's in 10 years of experience, so it's exceedingly rare. And here you see one of the original series from 2002 in which they reported 2 examples of women with vision loss in their early 40s with primary empty cella syndrome, and these were true primary empty cellas, so exceedingly rare to have a need for chiasmopexy in this population. But these 2 cases were managed by a surgeon who did chiasmopexy and noted some small but documentable improvement in vision in these patients. And I should mention it was small, and that's an important take-home point, that chiasmopexy may help these patients, but it may not always completely work. And here's another example of that. This is the symptom, the example of patients that I saw in my practice with vision loss and an empty cella syndrome, which is the treated prolactinoma patients, because the response to the dopamine agonist is so good that these patients can develop empty cella and sometimes can develop downward herniation. So you can see here that this patient had diagnosis of 50-year-old female with a large prolactinoma, and there was vision loss at the time, particularly in the right eye. The left eye was pretty good from the tumor, and then you can see after dopamine agonist treatment, the vision normalized. The patient just had their normal blind spot. And then you can see that after continued treatment with dopamine agonists, the optic chiasm actually began to herniate downward, and the patient developed recurrence of that visual symptoms in that eye that they had, as well as in the other eye. And so that patient was taken to the operating room for chiasmopexy. And you can see that one eye improved completely and normalized. The other eye, the lateral defect improved, but then they did develop a new defect. So again, a caution that chiasmopexy is by no means a 100% curative for vision problems, and it can sometimes cause new vision problems, because you can imagine this is a very delicate nerve, and it's now been pulled downwards, and you're pushing it back up, and the nerve doesn't always respond to that manipulation perfectly. But in select patients, chiasmopexy can play a role when they have empty cella and vision loss. So in conclusion, I hope I've shown you that an empty cella syndrome is a syndrome in which the cella has a pituitary gland that is partially or completely involuted, and it's a fairly common imaging finding. It's rarely going to be symptomatic, but when it is, it can be a manifestation of conditions in the pituitary gland or outside the pituitary gland. Primary empty cella syndrome is a manifestation of conditions outside the pituitary gland and can occur with pregnancy, obesity, or intracranial hypertension or pseudotumor cerebri. These patients should be evaluated with, as well, along with their signs or symptoms, which can include vision loss and headaches. Secondary empty cella syndrome, on the other hand, occurs after injury or insult to the gland, and those patients will only need intervention if they have some sort of tumor that's identified, or if they have symptoms that need management, such as chiasmatic prolapse, which can occasionally need chiasmopexy. And so with that, I'd like to thank you for your time and open it up to any questions from the audience.
That was very interesting. Thank you. I do have a couple of questions. The first one, I have had an empty cella due to tumor removal and radiation for close to 30 years. Medication always affects me differently. Is there a reason why?
Well, if you're speaking about medication in general, there can be interactions between some medications and having hypopituitarism in terms, and so that, it's certainly one possible explanation.
Okay. Someone else has asked if it would be possible to receive a copy of your presentation.
I certainly don't mind sharing it. That's fine.
Okay, and we'll be in touch and we'll get that to you. You mentioned dynamic MRI. Can you describe that a little bit more? Like if they were going to ask for that from their doctor, how would they go about that?
So dynamic MRI, the basic concept is that the pituitary gland and tumors in the pituitary gland clear the gadolinium, the contrast that we give with the MRI, in a varying time course. And so if you just get a normal pituitary MRI, they are going to take those pictures of the pituitary gland at a specific time after the intravenous contrast has been given. It may be 1 or 2 minutes. But a dynamic MRI is where you have to be looking just at the pituitary, and you take multiple pictures at 10 seconds, 30 seconds, 1 minute after the contrast. And the hope is that by collecting all of those images, you get a dynamic picture of the clearance of contrast and get more definitive information as to whether there's a tumor or something worrisome in there.
Can dynamic MRIs be done at most centers, or is it mainly the pituitary centers that do those types?
It's definitely available at pituitary centers. I'm finding that it's becoming more available at non-pituitary centers over time. It does not require any advanced technology. It just requires that the protocol be part of the standard tools that the center uses. And more centers are becoming aware of it and making it an option, and they certainly all have the technology to do so, but you just have to ask on a case-by-case basis.
Okay. Next question. I have an empty cella from a stock severance in an accident. I am pan-hypopituitary. I just had cataract surgery, but my vision is not as improved as expected. Would I need a pituitary 3T MRI to determine if I need a chiasmopexy?
I think that's a reasonable step to take. The chances of it proving to be appropriate are not high, but given your condition, it is one possible explanation for failure of vision to improve, and an MRI to take a look at your chiasm would be very reasonable.
Okay, is it possible for a patient's vision to get better or worse on some days versus others?
We have seen that in general, and I think anecdotally in talking to colleagues, there's some people who feel like the empty cella patients with vision loss in particular experience that day-to-day fluctuation. The theory and possible would be that it's not a tumor per se, but rather a nerve floating in fluid, and so it may be more prone to day-to-day fluctuations, but it's really hard to prove that.
Okay, interesting. Could meningitis cause partially empty cella?
It would be unlikely, but not impossible. If it were to cause an empty cella, in general, it would mean that the meningitis were affecting the pituitary, and the possible mechanism for that would be high intracranial pressure as a consequence of the meningitis, as a possible explanation, but certainly not something we typically see.
Okay, this is not a question, more of a comment, kind of an interesting one. Hi, I'm listening here. FYI, my uncle, Dr. Oscar Riddle, was the first scientist to isolate the pituitary hormone prolactin. Thank you for the webinar. It's interesting.
Interesting.
Yeah, doesn't look like I have any more questions right now. If anybody has any questions, please send them in. Oh, just got another one. I have an empty cella, had surgery and radiation. Some days are better than others with my vision. When my inside of my ears get puffy, my vision gets worse. Any ideas?
Boy, that's hard to be certain based on that information, but in general, the empty sella is something that could, in theory, get worse when your intracranial pressure is high. And so if the puffy ears were somehow a manifestation of having high pressure, such as when we all do a Valsalva type maneuver, it's possible that could be the explanation, but that's a tough one to fully grasp.
Okay. Can any pituitary center evaluate an MRI regarding the need for chiasmopexy, or is it necessary to see a specialist like you?
I think the initial discussion can be done anywhere. The provider you're talking to obviously needs to be familiar with chiasmopexy, and it is exceedingly rare. I think the operation is not performed very commonly, but if you had a provider who understood what it was and what its usage would be, then I think there may be providers like that it's, you know, as long as they're comfortable with it. It might be outside of a center. It's hard to say.
Okay. Any more questions? Oh, there's another one. Having empty sella syndrome then does not affect me as I am panhypopituitary. That then is my main medical issue. Is that the case?
It is true that the majority of empty sella syndrome patients, the most common symptom will be having panhypopituitarism. And in that case, the hormone replacement is done just like any other patient with hypopituitarism, and the empty sella is really just, you know, it's just an imaging finding in a patient like that.
Okay, thank you. Any other questions? Oh, thank you. I think that will do it for questions. It's been very informative. Thank you very much. We really appreciate you doing this for us today. Somebody's asking, do you take on new patients?
Absolutely. I can give, how would I get that info?
I can send the information to you on how to contact Dr. Aghi.
Great.
Yeah, we can do that. All right, this concludes our webinar presentation. And, oh, I got another, please send me too, so I will do that. I think we got through all the questions, so we don't need to answer any by email. The P&A wishes to thank you for participating in our webinar. There'll be a brief survey after the webinar. Please fill it out to help us provide you with the information that you need. Dr. Aghi, we thank you very much for doing our webinar for us today. Thank you everybody for attending, and we will see you next month.
Thank you.
Thank you.